Thank you very much. Thank you. So we have like, I think, 2 minutes for questions. So I'd like to call both speakers to have a seat. Yes, any question? اتفضل دكتور.
Assalamu alaikum wa rahmatullah. Sabah al-khair Jamil. Thank you for both excellent speech. I have a question to Dr. Abdullah Malki. I'm a pediatric rheumatologist. From your presentation, you taking care of those patients. Are they nephrologists or rheumatologists? Because I believe there is some difference between the approach between the two specialties, at least from pediatric point of view. We have difference in the practice between nephrologists and rheumatologists. So probably this is need to be clarified, who is taking care of those. And also, probably I missed that. How many of your patients ended with renal failure, and if there is any of them went for transplant? And I think it will be more informative if you compare the adult with pediatric. We know pediatric patients, they have severe disease. But I think since you are talking about Saudi experience, probably it will be adding a value for that. Thank you.
Good question, thank you. So yeah, actually it was more of adult population. However, there were a few pediatric patients, and I noticed with pediatric cases, they have higher creatinine level, and they are using more of the CNI, cyclosporine of tacrolimus, as compared to the adult. And we know CNI are nephrotoxic, and we see this in the referral. More CNI are used in pediatric multi-target kind of management. The management was primarily by nephrologist. In our studies, it was by nephrologist, not rheumatologist. And your question about dialysis, yes, we had a good number of patients who ended in dialysis. As I said, 16%, 5 patients at the initial presentation within 6 months, and additional 11% as a long term. So 16% of patients, they went into dialysis over a follow-up, or a median follow-up of 48 months.
Do you think there was
transplant? We did not. I did not look for transplant, and also for relapse and treatment of relapse.
Do you think there was a delay in the diagnosis for pediatric patients?
You know, it was only few patients, not much of pediatric, because we excluded pediatric. But it was only few patients with pediatric, less than like 10. They were at, you know, the age cutoff pediatric for our population and management by adult nephrologists is different from the Western cutoff age. So that's why we included them. It was only few, so it's difficult to make conclusion out of this. Yeah.
Okay. Any other question?
Thank you, both speakers, for amazing talk. My question for Prof. Hani regarding the ultrasound. With this evidence of false positive finding in ultrasound, and when you assess the patient and you don't want to put yourself in the dilemma with this positive, false positive result, which patient you choose to send patient for ultrasound assessment? Are you sending all your patient, or when you have a clinical doubt and you are not quietly sure this patient doesn't have arthritis?
Quick answer, Dr. Muhammad, I don't use ultrasound in my day-to-day practice. I use ultrasound if I want to confirm my diagnosis. If I want to confirm my presence of arthritis, as I told in my examples, I would prefer MRI than ultrasound. In my day-to-day practice, I don't use ultrasound at all, because I believe relying more on my bedside skills, on history point, physical exam, lab findings, I'll be more than competent enough to diagnose my patient with arthritis. However, I know some colleagues have added value by having ultrasonographers done for them. So you have to be careful interpreting the abnormal, what's reported for abnormal findings, because not all abnormal findings are true abnormalities. Some of them could be in normal population. So still you need to base your interpretation on your clinical skills. Myself, I would use ultrasound mainly if patient cannot do MRI for the shoulder. I would do MRI ultrasound just to confirm diagnosis of tear. I don't need ultrasound to diagnose rotator cuff tendinitis, but if I'm suspecting tear and the patient cannot do MRI, I will do ultrasound because of cost. So in my practice, honestly, ultrasound use is very limited. I know other colleagues may not agree with me, but this is how I do things.
Okay, thank you.
Because of time, we'll take the last question.
السلام عليكم ورحمة الله. أنا خالد إسماعيل الماسكروسكوبي radiologist.
طيب دكتور خالد أنا
just
طيب شكرا يا جماعة أنا أروح.
الله يستر أمركم. I agree 100% with you, Prof. Hani, about the clinical examination maintenance and training, and we should go for the clinical assessment before any other investigations. But we should be in the other hand in the balance. So definitely we have to have imaging even by plain X-rays. So the title doesn't reflect the radiological or imaging processes, which includes plain X-rays, CT, MR, interventional procedures. Nowadays, even AI, they are applied for the joint or arthropathic changes. So what I believe, we should be in a balance. We should definitely support 100% the clinical assessment before doing other examinations. We know that the Canadian groups, US groups, they don't accept doing the MRI for the back pain, low back pain, and you send the patient for MR sacroiliac joints. So the insurance companies, they don't definitely agree for this unless certain procedures has been done. And this probably caused some sort of delay. The second point is that having ultrasound examination or ultrasound bedside clinic ultrasound, it should have, as what you said, objectives. So diagnosing alone on the bedside by ultrasound without keeping images or without references, without reports, this is definitely illegal and probably medico-legally issues. So I think that we should be in the middle, balanced. We have the clinical aspects, we have radiological aspects, and this is definitely in the international working groups like ASAS and et cetera, et cetera. So you cannot omit one of these. You should have both wings to fly. If you have just the final word, it's yours.
No, it's
Thank
great.
you.
I agree 100% with you, Dr. Khalid. You are, mashallah, one of the experts in the kingdom about musculoskeletal imaging. And you were referring to access, back pain, and things. And my points were mainly on the small joints. I would agree 100%. We are talking the same language, by the way. I'm maybe biased. I'm considering mainly rheumatoid arthritis, small joints, rather than the huge picture of musculoskeletal medicine. Still, X-ray need to be done for patients with monoarthritis to rule out fractures, to rule out. I didn't present it from radiological holistic approach. I was so focused on small joints, to be honest, arthritis, and the rest is I agree 100% with all what you have mentioned.
Yes,
Yes, Dr. Osama.
I think it's time in the maturity in the field of rheumatology to extend our cooperation with all specialty. I have a dream for you that one day you will have a lupus nephritis clinic, and we have to have cooperation, multidisciplinary approach between nephrology in your institution, and it will be broadcasted. Because this confliction in daily clinical practice, while you are doing near biopsy, you should wait until creatinine is high. This is a controversy. We need to have something on the ground based on daily clinical practice. This success, we can refer. We should not wait the patient to reach the final stage to prove that it is lupus nephritis, especially the 2019 guideline criteria include lupus nephritis as a diagnostic criteria in addition to NA. Just a dream. We have to implement this in daily clinical practice. Radiology, yes, we have to duplicate Dr. Khalid in each area of Saudi Arabia, and we have to cooperate with each other. If anyone doing any referral to radiology without a proper diagnosis, without objective assessment, as you stated, This is bad utilization. We are not experienced. بالمصري ادي العيش خالد خباز.
دكتور المايك بس عشان نسمع. Use the mic, doctor.
Yes.
Use the mic.
بالمصري ادي العيش لخبازه. What does it mean? I'm not aware of synovitis. Yes, I can diagnose by ultrasound, but Dr. Khalid can rule out any other. It can be malignancy, it can be something else. That's why the best utilization, not by any radiologist, the best utilization is musculoskeletal radiology. And again, for each center, we have at least one with musculoskeletal radiology to implement what we have. But we have to save our time, especially in the next few years with recession, with limited resources. We have to be rationalize what we are doing daily clinical practice.
شكرا دكتور. Comments.
Yeah. We can have more questions. We have time. Anybody wants to ask?
I have questions for Dr. Abdullah. So
تفضل.
Dr. Abdullah, thanks you. I'm really excited about your topic more than my topic. Now, membranoproliferative disease, how would you work with them? Because always, we are not nephrologists, but you will see your report, membranoproliferative. I know that you have certain things, but what did you use here so we can follow you in your study? Then another thing, you didn't comment about the use of plaquenil in your cohort of patients. And third thing, what do you think about now the new evidence of adding IV belimumab on the standard of care? Should we adopt this? Adding the new biologic,
Yes.
anti-bless.
Okay. So the first question about membranoproliferative, you mean as with lupus?
Yeah. In the biopsy report with membranoproliferative, what sort of, how did you classify them? What did you follow in your cohort? And please, Dr. Mike, عشان نسمع.
Yeah, sure. So, no, membranoproliferative is different, but maybe you see it like a histological description. Lupus nephritis definitely will have proliferative lesions, basically like class 3 or 4. That's proliferative, and if there is membrane thickening, then it becomes membranoproliferative. So it's just a descriptive term. But the membranoproliferative MPGN disease is different from the lupus, and there's new classification to this, and is more of complement dysregulation related disorder, like C3GN. But the term, the histopathology description, membranoproliferative, just indicate there is proliferative lesion, 3 or 4 plus 5. So you're talking about the mixed disorder.
So how did you classify them? The class 4 or class 5?
It will be mixed.
Mixed.
Class 3 plus.
How many of them were in your cohort?
In our biopsy, 15% of our patients, they have the mixed membranous thickening, which is class 5, plus proliferative lesions, which is 3 or 4. So 15% in our population were mixed disorder. As for the plaquenil or the hydroxychloroquine used in lupus nephritis, yes, I didn't actually talk much about the treatment because of the time, but yes, it's not only a rheumatology to prescribe hydroxychloroquine. These medications are, number one, they are immunomodulating, so they have a role basically in blocking the toll-like receptor and therefore block the signaling pathway in the dendritic cells especially. So they have effect on the innate immunity. It also has an anti-inflammatory and anti-thrombotic effect. It was proven in observation studies that they, first of all, induces or potentiate the remission by 1 year, reduces the flare of lupus nephritis, as well as delay the progression to end-stage disease. So these medications has to be part of the treatment, but of course we should avoid high doses because of the retinal toxicity. We don't recommend going beyond 400 daily or a cumulative about 1,000 gram of hydroxychloroquine. We should really be careful about this, or at least screen our patient for the retinal damage. So that is the plaquenil. And the last question was the use of biologics. There's a number of biologics added to the standard of care. The most commonly one used is the rituximab. However, the LUNAR phase 3 RCT was not very encouraging. It didn't really add much to the standard of care. And despite this, there's a number of observation studies have shown some positive outcome with rituximab. So in nephrology, we use it, but it's not the first line. We use it as treatment for refractory disease, and also we use it as maintenance treatment for those patients who cannot tolerate or who are refractory to MMF or azathioprine.
Thank you
The question
very
about,
much.
sorry, about belimumab.
Belimumab.
The new study that
Yes,
the
yes.
tuximab, yeah, we don't.
As of now, yes, there is ongoing studies on these.
Yeah.
There is few trials, but it's not enough evidence to make a recommendation. So in nephrology, recommendations, they are not part of the treatment.
I think we have to stop here.
Sure.
So thank you very much for both speakers, and we finish our morning session for this morning. Thank you very much.
Thank you.